Hello, my name is George Yang, and I'm from the Department of Neurosurgery at the University of Cincinnati. Today, we will be discussing the topic of surgical considerations for patients with polytrauma. My co-authors for this chapter are Drs. Mark Mahil, Amy Makeley, and Laura Nguyen. The key concepts we will review in this PowerPoint are listed here and will include triage considerations, damage control surgery, the timing of definitive treatment of non-life-threatening injuries with an orthopedic example, and guidelines in the postoperative critical care period. The immediate identification and triage of extracranial injuries is the first and most important principle in polytrauma management. The primary survey of the neurotrauma patient should proceed from head down in typical fashion according to ATLS guidelines, with particular focus on the head, eyes, neck, and back. The neurologic examination of the TBI patient unfortunately has many confounders. Altered mental status can be as a result of inadequate resuscitation, sedating or paralytic medications, and intoxication. Facial swelling can prevent the eye examination for pupillary response, and extremity fractures or high cervical cord injuries may limit limb movements. In patients with spinal cord injuries, commands such as open your eyes and stick out your tongue may be more effective to evaluate mental status. During initial evaluation, the focused assessment with sonography for trauma, otherwise known as the FAST, and chest radiograph will identify many tracheobronchial injuries in large hemothoraces or pneumothoraces. These images should be obtained prior to definitive imaging to identify and treat sources of hemodynamic instability. After obtaining X-rays and stabilizing the patient, a comprehensive assessment of all injuries by whole-body CT imaging should be performed in stable patients. If there is high concern for traumatic brain injury, empiric treatment with airway control, mild hyperventilation, hypertonic saline administration, seizure prophylaxis, and reverse Trendelenburg positioning are recommended. Table 395-1, shown here, highlights the most common emergent and urgent indications for intervention in polytrauma patients. I will briefly discuss these categories, but for additional discussion, please refer to the chapter for detailed descriptions. Tracheobronchial tree injuries require a high index of suspicion. If these injuries are identified and can be bridged with an endotracheal tube, stent, or surgical airway, the patient can proceed to additional imaging with a plan to delay definitive surgical treatment. Intrathoracic injuries such as root fractures can largely be managed with supportive interventions. However, intention pneumothorax, open pneumothorax, and massive hemothorax patients will likely require immediate treatment for hemodynamic instability. Cardiac tamponade can also be identified on the FAST and requires immediate intervention. Abdominal and pelvic hemorrhages with hemodynamic instability require immediate intervention, with plans to obtain postoperative imaging to fully define additional injuries. However, if the patient is hemodynamically stable, additional evaluation can be performed. The primary orthopedic injury that requires immediate intervention is an open book pelvic fracture. If this can be temporized with a sheet, pelvic binder, or teapot device, additional imaging can be obtained. Orthopedic injuries without associated hemodynamic instability are not life-threatening and can be managed in a delayed fashion, an example of which we will discuss later. Neurosurgical indications for surgery are listed here. However, details of management are discussed in other chapters. Damage control surgery, which includes truncated surgical procedures to maintain hemostasis, should be performed for life-threatening injuries. The primary goal is to achieve surgical hemostasis and control of contamination to allow for resuscitation in the ICU. By limiting the initial surgical insult, damage control surgery has resulted in decreased mortality compared to definitive surgery to address all injuries at the index operation. In the setting of polyneurotrauma, the treatment of non-life-threatening injury should be delayed until the stabilization of the traumatic brain injury. From a pathophysiological perspective, an inadequately resuscitated patient is likely to be challenged by coagulopathy, hypothermia, and metabolic acidosis. There is evidence that early total care of orthopedic fractures with surgery may potentially aggravate this lethal triad. Early total care is also associated with increased ICP and decreased CPP, both recognized as independent predictors of adverse outcomes after TBI. Damage control orthopedics is a subtype of DCS that includes immediate temporary stabilization through external fixation to facilitate early transfer to the ICU. Advocates of DCO promote a staged surgical approach in TBI patients. A retrospective analysis demonstrated that delayed treatment of femoral shaft fractures beyond 12 hours after appropriate resuscitation reduced mortality by half when compared to patients undergoing early total care. There is also an associated decrease in complications and shorter ICU stays. On the next slide, we will discuss an example of damage control orthopedics in a patient. Figure 395-1 demonstrates a clinical case of damage control surgery, or in this case, damage control orthopedics. This is a young female who presents after a high-speed motor vehicle accident with a severe traumatic brain injury, demonstrated in picture A. Pelvic ring disruption, proximal femur fracture, and femur shaft fracture. Image D demonstrates the result of initial fracture treatment with closed reduction and external fixation of the pelvis, as well as spanning the external fixation of the femur. After 10 days in the ICU, the patient recovered from the TBI and scheduled conversion of internal fixation through intramedullary nailing of the femur and iliosacral screws to stabilize the posterior pelvic ring was performed. Anterior fixation of the pelvic ring remained in place for 3 months for further non-operative management. The final X-rays are demonstrated in Figure E. Much of our current management is based on retrospective data, and until higher evidence data is available, common sense pragmatic approaches can be applied. Figure 395-2 demonstrates a proposed pragmatic approach for femur fractures in patients with TBI from Fleurel's 2010 paper on early total care versus damage control orthopedics based on GCS. For mild TBI patients with a GCS of 14 to 15 and a normal head CT or head CT with mild intracranial pathology, they advocate early total care with immediate intramedullary stabilization of the femoral shaft within 24 hours. For patients with moderate and severe TBI, regardless of imaging findings, they recommend damage control orthopedics with immediate temporary stabilization of the femoral shaft with staged conversion into intramedullary nailing. The time to convert to internal fixation is after recovery to an alert or an awake state with GCS greater than 12, or when the patient has had a normal ICP and CPP for greater than 48 hours while comatose. The goal of critical care in the polytrauma patient is to optimize cerebral perfusion and avoid intracranial hypertension and hypoxia. We will not discuss specific parameters such as ICP, CPP, and etc. because other chapters in this book cover these topics in depth. For patients with concomitant abdominal injuries, it is worthwhile to consider that increased intra-abdominal pressures may contribute to elevated ICPs by impeding venous return, mean arterial pressures, and resultant increased ICP. Treatment of these elevated abdominal pressures with temporary decompression can address this. However, the sedation required for patients with these open abdomens interferes with frequent examinations. For these patients, it is worthwhile to consider continuous intracranial pressure monitoring. Patients with significant respiratory illness, such as pulmonary contusions, atelectasis, fat emboli, pneumonia, or ARDS, can benefit from close monitoring of brain tissue oxygenation. PbTO2 can give providers a hint that pulmonary insufficiency is developing with an associated decrease in PbTO2 prior to a decrease in PaO2. That being said, aggressive ARDS management can be difficult in severe traumatic brain injury patients. Prone positioning as a treatment modality is difficult in TBI patients because it has been reported to raise ICP. However, if needed, discussions between neurosurgery and trauma should be had to determine feasibility on a case-by-case basis. A dedicated neurocritical care team is also worth consideration because there is significant value in the development of protocol-driven therapies in traumatic brain injury. This team should be familiar with polytrauma patients, and nurses should be trained in neurological conditions. In conclusion, the management of the polyneurotrauma patient requires additional considerations, ultimately with the primary focus on stabilizing patients and treating immediate threats to life. The secondary goal is to prevent neurologic injury from hypotension, hypoxia, and elevated ICP. These goals are achieved through a combination of pre-hospital efforts, ATLS management, and multidisciplinary care upon arrival to the hospital. Once in the hospital, damage control surgery for thoracic, abdominal, and orthopedic injuries are the mainstay of treatment. Multidisciplinary consensus regarding treatment priority and protocols can improve outcomes and should be employed at most institutions. Thank you for your attention.